Welcome to our fourth COVID-19 Symposium from the New York Medical College and the Touro College and University System. I am once again your host. My name is Edward Halperin. I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. We gathered once in person on March 30th in Manhattan, and we have gathered online on April 6th and on May 6th. And here we are again on June 18th for our fourth symposium. For those of you who are repeat attendees, you will see some of our faculty who are becoming, I suppose, old friends by now through these symposia and webinars. Drs. Alan Kadish, Robert Amler, and Janet Piscatelli. You're going to meet some new friends today, Drs. Jerry Nadler, Ronnie Myers, Renee Garrick, Robert Rubin, and John Pellicone. But first, let's attend to two housekeeping details. For those of you who want continuing medical education credit, here's how to sign up. Text the code 09CLOP, 09CLOP. Text that code to 828-295-1144, or go to www.eeds.com, click the sign-in button, and enter that same code. The code will expire on June 20th at 1 p.m., so I recommend that if you want your CME credit, don't forget, go ahead and do it promptly. Now, if you don't have a pencil to write down these instructions, perhaps you want to grab your cell phone and take a picture of the screen, or maybe you want to do a screenshot. Second, we're going to skip interruptions in the flow of our webinar today with recitations of our speakers' qualifications. We'll just spend more time conveying information and less on reading you people's CVs. I'm going to see you again during today's program to repeat the CME instructions, so don't worry if you didn't write it down or take that picture with your cell phone. I'll be back and show you the slide again. And I'll also be back to have a chat with Drs. Garrett and Pellicone and to moderate the question and answer section. So remember, type your questions into the question and answer section of your Zoom screen. Let's get started by hearing from the president of the Touro College and University System for an introduction and welcome, Dr. Alan Kadish.
Welcome to the fourth New York Medical College Center for Disaster Medicine Touro Conference on the COVID-19 pandemic. The Center for Disaster Medicine at New York Medical College is the only New York State funded center of excellence dealing with the response to a variety of urgent situations, including pandemics. In addition to training emergency responders, the center provides state-of-the-art education for professionals and for the public. The center is part of New York Medical College, a member of the Touro College and University System. In the past 4 months, we have learned a great deal about the SARS-CoV-2 virus, but there is also a great deal that we still need to learn. We have learned that pre-symptomatic and asymptomatic spread can occur, although the full incidence of that in producing the disease is still not fully clarified. We have learned that face masks provide a good deal of protection from disease transmission because the major mode of transmission is respiratory droplets. We have learned that the disease is highly fatal in the elderly and in people with underlying health conditions. We've also learned that certain races are more susceptible to dying and getting coronavirus. We've learned that 2 drugs have some efficacy in treating advanced COVID infection, but we await confirmation that other drugs can prevent the spread of disease or treat it when given early. We've also learned that protection is very effective. The best evidence of this is that healthcare workers are at a lower risk of COVID infection than others because they have been so scrupulous in wearing protection. That's an important lesson for all of us. What's not clear? What type of testing is available? And is there evidence that testing can truly be helpful in stopping the spread of disease? When is it safe to resume business activity, educational activity, and recreation? We still don't know for sure. Why is it that the elderly and people with certain diseases seem to be at much higher risk for COVID-19? Will a vaccine be available and when? Will life ever get back to normal? We hope to address these and other timely questions regarding the COVID-19 pandemic in today's talks. We know that working together with scientific advances can really help us to tame the current pandemic, which at times has been scary and seem out of control. To try to help begin our journey to understanding where we are as of today regarding coronavirus, our first speaker is Dr. Robert Amler, Dean of the School of Health Science and Practice at New York Medical College and Vice President for Governmental Affairs. He's a former CDC official and our preeminent expert on public health. Welcome, Dr. Amler, and thank you for joining us today.
Good afternoon. I'm Dr. Robert Amler. I have no conflicts of interest to disclose. The question I've been asked to address is, why are minorities hit so hard with this COVID-19 pandemic? What do the data show, and what can we do about it? Well, here are the data from New York City. Imperfect data, yes, but look at the trend. When you look across the slide, you can see that the different groups have remarkably different attack rates, whether they are actual case rates, hospitalization rates, or death rates. And these are rates, not just raw numbers. They are rates per 100,000 population. Now let's look at some of the inconsistencies before we try to interpret. If you can follow my cursor down in the lower left, you'll see that where cases are counted, we estimate only 24% were reported. A better reporting ratio for hospitalization cases, and an even higher ratio, but still not perfect, for deaths that are reported. So there's inconsistent reporting and inconsistent testing, but still look at the trends. It's clear that African American people are faring far worse during this outbreak in New York City than Hispanic, Latino, who are doing worse again than white, and Asian populations so far have fared the best with the best outcomes from this pandemic. Well, we need to ask, why has this happened? The CDC has pointed to 6 broad areas, and yet, as a scientist, as an epidemiologist, I have to say, when somebody gives me 6 reasons something's happened, I'm always a little skeptical that maybe we haven't found the root cause. And I would suggest that it may well be this last one, systemic inequities, that really lie at the root of all of these other factors. But we can look in greater depth at some of these factors. If you knew New York City, you know this is where many people live, and this is where many people go to get to work, to school, or to daily activity. We know that living conditions are, in fact, very dense in places like New York City, and this especially is a factor for racial and ethnic minorities who often live in segregated residential areas, who often live in multi-generational housing, where different family members from different generations are posed in close proximity where they can infect the older members of the household. We know that there's also some institutional clustering that occurs, particularly in congregate facilities, which may be more clustered in those places that serve racial and ethnic minorities. The work circumstances are more difficult as well for minorities. We know transportation. Just look at that subway car and consider the opportunity for COVID virus to travel from one person to another, closely packed, well within the 6-foot distance that we try to maintain ideally. In addition, minorities often are in lower wage, higher risk jobs where the risks of exposure may be higher, and in turn they may have inadequate sick leave in many of the workplaces, which will induce them to come to work even if they're not feeling up to snuff and potentially infect others. Well, we know that there are underlying health conditions as well that are more prevalent in racial and ethnic minorities. Diabetes, hypertension, cardiovascular, and there's a potential mechanism here because we're learning more and more that the real severe complications of COVID are related to microemboli and embolic phenomenon that cause blood clots in very dangerous locations in the body and can lead to severe deterioration and even death. In addition, we know that access to health care is a big disparity, not just in New York, but coast to coast. Again, I mentioned inadequate sick leave, inadequate health insurance, which will make it more difficult for people to seek care when they are sick. Fragmented care, with people getting lower quality care, both because they're seen by inconsistent providers who don't know their full history, who don't know their full list of medications, but also that healthcare becomes more erratic and there's less consistency in their treatment plans, and in many instances, less access to testing. Well, I mentioned system-wide inequities, and this could be an entire seminar on its own, but simply to point out that we know that there are glaring disparities across the country in life expectancy at birth, in life expectancy or years of life in older people as well. And we know that socioeconomic status still plays a big role in the outcomes for a whole variety of health conditions. Socioeconomic status, which affects educational level, nutritional level, mobility, and ultimately consumer power to select the kind of healthcare and the kind of treatments that are going to be most effective for the individual consumer. So there we are with this deadly set of discrepancies, but we are not stuck in cement. There are basic things that we can do about it, and this, if I may say, is our pathway to improvement, which also equals essentially Public Health 101. These are basic public health strategies, proven, tried and true, that begin with community engagement across the sectors, promoting good behaviors and promoting health care, but has to be done with full participation and partnership with communities. These are the basic tenets of health promotion, health education, and risk communication to reach out to thought leaders in communities, to establish meaningful ties with people throughout the area, and getting people engaged and giving them a sense of buy-in to the types of things that the experts are recommending to reduce the risk of transmission. Finally, we have to step up our surveillance, investigations, and response, which now is happening with the greatly increased contact tracing initiative that is underway in the New York area and in other parts of the country. And finally, this is the endpoint that we all seek. We're looking forward to the day when we can whip out this handy-dandy manual from the American Public Health Association and turn to this new page, as yet unwritten, that gives us all of the actions and interventions tried and true to defeat this awful pathogen. Thank you.
Good afternoon. My name is Dr. Jerry Nadler, and I am Professor of Medicine and Pharmacology and Dean of the School of Medicine, New York Medical College. And I'm pleased to give this important talk related to the impact of diabetes on COVID-19. I have no disclosures. So diabetes and COVID-19 is a serious interaction. There are higher risks of mortality and morbidity associated with this. Diabetes is, especially type 2, is at epidemic rates in the United States, so they're very common, and it's disproportionately affecting people of color. Diabetes is a common underlying condition of COVID-19 cases, up to 30%, and this can lead to 6 times the hospitalization rate and up to 12 times the mortality rate. This data just came out yesterday, 2 days ago, in the CDC annual weekly report. Patients often show changes in glucose control and can develop diabetic ketoacidosis or hyperosmolar coma, so you need to be aware of that. And a study recently showed that 1,300 hospitalized patients with diabetes, that the pre-admission BMI was positively associated with tracheal intubation and death within 7 days. Now here's an example of a series from China that looked at hospitalized patients with diabetes or without diabetes. And from this slide, you can see an example on the left, an A, non-diabetic and diabetic patients, the lung CT showing more severe disease in the diabetic patients. On the right, on the section B, is a summarized data showing increased CT score, complexity, and severity in the diabetic patients. So this is an example of the lung pathology that you can see increasing in patients with diabetes and COVID-19. Now, why do you see increased risks of complications and severity in people with diabetes who also have COVID-19? There are several mechanisms. It's not all been worked out. Here are a few of them from very recent studies that I provide the references on the bottom. First off, people with diabetes are in a pro-inflammatory state with higher risk of cardiac and other organ damage. This sets up patients for increased risks of the disease. Second, type 2 diabetes is associated with risks of thrombosis, and we now know that increased clotting is a major problem that we're seeing in patients with COVID-19. Third, COVID-19 infection can worsen glucose control, leading to increased risks of complications. Fourth, this is very new data that was just published in the New England Journal of Medicine, that a registry has been formed to study whether COVID-19 can actually lead to new onset diabetes by damaging some of the tissues or leading to insulin resistance. And finally, studies indicate that changes in immune cell function can lead to increased risk of infection and complications in patients with diabetes and COVID-19. The next slide summarizes some of these changes in a visual form. And here is from a recent study showing putative mechanisms contributing to increased susceptibility for coronavirus infection in patients with diabetes. First, the entry of SARS-CoV-19 into the respiratory tract occurs through the usual route of inhalation, and the infection in the respiratory epithelium leads to necrosis and damage to the lung epithelium. That could lead to severe pneumonia, ARDS, and needing intubation. Now, patients with diabetes show impaired macrophage activity, impaired neutrophil recruitment, impaired immune cell function, leading to increased infection, along with the receptor for SARS-CoV-19, ACE2 expression is increased. This could lead to cardiac dysfunction, acute renal injury, and further damaging the cardiovascular and pulmonary system. In addition, patients with diabetes are in an inflammatory state, and you can get the cytokine storm, which we now know leads to severe disease in patients with COVID-19. So here are some mechanisms that explain the increased risks of people with diabetes and COVID-19. Now, how do we prevent the problems and manage the patients? This is a very extensive discussion that hard to cover in just 7 minutes, but in the top part of this slide is the area I want to focus on. Prevention is very, very important. You want to continue regular glucose lowering therapy. You want to monitor your therapy in the patients with diabetes. You want to have them maintain a very healthy lifestyle and minimize, most important, minimize exposure to the SARS-CoV-19 through telemedicine, home drug delivery, use of hygiene, masks. If they are on ACE inhibitors or ARBs for their hypertension or renal protection, the recommendation is to continue these under medical supervision. We all wish we have a vaccine. There's extensive research going on there, and also pre and post exposure chemoprophylaxis. We hope that'll be the case, but right now we don't have these. So we want to prevent COVID-19 in people with diabetes. For glycemic control, if they're asymptomatic infection, maintain same therapy they have at home. If they're symptomatic or require hospitalization or ICU care, typically insulin is the major therapy used, and oral agents are typically stopped. And comorbidity control, cautious use of other medications as illustrated here. So I wanted to summarize the take-home points of diabetes and COVID-19 in this slide. These are the key take-home messages. Guidance has now been released for inpatient management that also reduces medical staff contact time for safety. And this just came out in the Journal of Clinical Endocrinology and Metabolism this month, which is very important for those of you managing patients in the hospital. For glycemic control in the hospital, people with diabetes and COVID-19 should primarily utilize insulin. Third, measures for prevention of infection are critically important. This includes hygiene that has been described, use of telemedicine for outpatient management to minimize contact with other people. Fourth, risks of hospitalization and mortality are increased in people with diabetes, and therefore we really want to have prevention as a primary mechanism to keep people from getting this disease. And it's very important for people with diabetes to follow all updated guidelines for nutrition, for physical activity, glucose monitoring, pharmacologic management, and to remain in good health. This is very important so that patients with diabetes hopefully will be prevented from getting COVID-19 until at least we can get an effective vaccine. I want to thank you for your attention, and thank you very much for listening to this important talk.
Good afternoon. I'm Dr. Janet Piscatelli, and I'm the Director of Pathology and Laboratory Services at the Westchester Medical Center Health Network. There is an incredible amount of confusion regarding laboratory testing for the COVID pandemic and the virus responsible, SARS-CoV-2. Thoughts around testing for diagnosis, surveillance, and exposure are continually changing. I was recently employed by Quest Diagnostics and continue to have equity in this company. For background, this is a figure of the detection of viral RNA and antibodies to the SARS-CoV-2 virus. Time in weeks are on the x-axis, and the increasing probability of detection are on the y-axis. All of these are approximations. There is a lag from exposure to symptoms, and that has been reported to be up to 2 weeks. However, there is an ability to detect viral RNA during this time. This figure indicates that detection is unlikely. This is not because of the sensitivity of the assays, but rather these people do not present for testing since they are asymptomatic. It is at this time, by using a surveillance program, that these exposed yet asymptomatic people can be identified and quarantined earlier. Samples from the nasopharynx continue to be positive, peaking at about 1 week of symptoms. They continue and slowly decrease, and by 4 weeks are usually undetectable. Samples from the stool and lung are detected for a longer period of time. Antibodies to the virus can be detected 2 weeks after symptoms appear. However, there is also an overlap with PCR positivity, so even a person mounts an immune response, they may be shedding virus. There is guidance from the CDC regarding proactive surveillance of asymptomatic people in certain settings. An example is long-term care facilities where we have seen this virus take an incredible toll. And any environment where there is a potential for exposure in a common setting with subsequent rapid transmission, such as workplace dormitories or colleges and universities. Proactive surveillance can be utilized along with social distancing at critical industries such as food plants or distribution centers. Surveillance can be performed using a rapid point-of-care device for nucleic acid amplification, which can deliver results within minutes. Decreased sensitivity has been observed with these devices. So if a person is positive after initially screening negative, then tracing and testing of potentially exposed contacts should be performed on a clinically diagnostic nucleic acid test. The same is true with serology, determination of the antigen in a person's blood. Antigen tests which detect the presence of the spike or nucleocapsid protein directly have sensitivities less than nucleic acid amplification, and therefore it is recommended that all negatives be confirmed with PCR testing. In a population where the prevalence is less than 5%, this would be extremely costly and non-additive. There is only one antigen assay that has received emergency use authorization from the FDA. The CDC also recommends pool testing, that is combining samples from people into one pool and testing the pool instead of the individual samples. This is optimal when the prevalence of the virus is low, less than 5%, and the population can be collected at one time and tracked using information technology. The benefits of pooling is the conservation of valuable laboratory resources, such as reagents and labor, as well as decreasing the time to results for people who test negative. For example, if you test a population of 1,000 people, you can pool their samples into pools of 5, and you are initially running 200 tests instead of 1,000. With a 5% prevalence, at most, 50 of the pools would be positive. 750 would be resulted as negative. The 250 people who were tested in the 50 pools that were positive would be retested individually and resulted. There would be a total number of actual tests performed of 450, not 1,000, a savings of 550 assays. There is only a savings, however, when the prevalence is low. Another concern is there may be decreased sensitivity due to dilution of weak positives, although there have been experiments performed that indicate pooling of 5 samples or less may be acceptable. The FDA is aware of the need to conserve resources, but at the same time test as many people as possible, and they are working out appropriate validation protocols which laboratories can adopt. As cities open up and people return to work, laboratory testing is not recommended unless people are in high-risk situations. Looking for early symptoms such as increased temperature and social distancing are the best tools we have at the present time. Creating a safe work environment is paramount, and employers can require employees to wear gloves and masks if necessary, as well as implement social distancing practices such as hand washing and separation of desks by 6 feet. For those high-risk situations, testing should accompany common sense. Isolation and contact tracing is of utmost importance, and there should be use of testing algorithms to optimally utilize precious testing resources. As a community, we should focus on those situations in which people who are at high risk, such as long-term care facilities, or situations in which social distancing is challenging. Unfortunately, there is not clear testing solutions that can be implemented easily with the given resources. Each individual workplace and setting needs to be assessed with appropriate plans to open, ensuring a safe environment. Thank you for your time today.
If you're seeking CME credit, text 828-295-1144. That's your phone number, 828-295-1144, and text the activity code 09CLOP. That's 09CLOP to 828-295-1144. Or on your website, go to www.eeds.com, click the sign-in button, and enter that same code, 09CLOP. Remember, however you're going to sign up for CME credit, do it before June 20th at 1 p.m. because at that point, the sign-in will expire. Either way that you do it, the system will walk you through the steps to get your CME credit, get your certificate, and fill out your evaluation of this program.
Good afternoon. I'm Dr. Ronnie Myers, and I'm the Dean of the Touro College of Dental Medicine. And I was asked to speak about, is it safe to go back to the dentist? So I think it's important for us to have a perspective from the historical standpoint of where dentistry has come in infection prevention and safety. And prior to 1960, there were actually no aerosols produced in the dental environment. At least there was no water spray in the dental environment. So dentists didn't wear masks and they didn't wear gloves. And it was really a day when even instruments were only boiled and not sterilized. But in the 60s, the advent of the high-speed handpiece and aerosol and water spray created a different environment. So people started to wear masks. But in the early 80s, with the AIDS epidemic, infection control took a new light in dentistry, and it became much more of what we did. And people started to begin to wear masks and their gloves and gowns and things like that. Prior to that, those of us educated before that didn't wear gloves. And in 1993, the CDC actually established guidelines for the practice of dentistry and infection prevention. And they updated those in 2003 when there was more research on infection prevention in dental care. And in 2016, they actually developed an app and a checklist so dentists could review their protocols and procedures in their office. And now we're challenged with COVID and how things have changed. We know that in any industry, in any occupation, there is risk, but we have to make the decision at who's at risk and how do we minimize the risk or mitigate the risk. And obviously in the firefighter arena, they obviously wear safety equipment, and even the mouse who's trying to get the cheese wears a helmet. But in the dental environment, actually the dentist is the person who is most at risk. And in fact, in this graph that was published in the New York Times back in March, graphing the exposures at work and the proximity to the exposure puts dentists at the top of the chain. They are exposed to diseases at work all the time, and they work in close proximity to the patient that they're practicing on. We look at the progression or the transmission of infection, let's say in any place, but there's always a pathogen, there's got to be a mode of transmission, there's got to be a susceptible host and a portal of entry. And in the COVID arena, we have the virus, obviously, mode of transmission by droplet or aerosol or fomite, a susceptible host, which would be the dentist or the patient, and the portal of entry. And the portal of entry, in this case, being the nose and the mouth, mucous membranes. And so what do? We wear a mask, we wear protective eyewear, and those sorts of things to prevent the portal of entry from accessing the virus. And in the dental world of handpiece and water spray and ultrasonic scalers, we produce a significant amount of aerosol. And that aerosol lingers in the air, and there has the potential for the spread of the virus. And also from a fomite standpoint, whether it be on instruments that are not managed correctly or countertops that are not covered and disinfected, we know that fomite transmission is very, very low, but there still is that potential. And so covering and disinfecting countertops, chairs, handles, furniture, et cetera, makes it a huge difference in trying to prevent the spread of infection. So things at the dental office will look and be different. We know that. How will they look different? How will they be different? So patients who call up with symptoms of an emergency, the use of teledentistry will take a more prominent role. And we know over these past 3 months, there's been a huge increase in teledentistry use in looking at emergencies. And in fact, when emergency care was the only care we could provide for the last 3 months up until June 1st, this was the main focus of trying to prevent patients from coming to the office unless they absolutely had to. Emergencies could be handled medically, they were handled medically. And if you're going to go to the dentist, obviously there'll be screening by the office, whether it be medical screening or COVID screening, asking you have symptoms of COVID, respiratory distress, fever, cough, and also if in fact you've been in contact with people who are positive or you've traveled in certain places. Those are types of screening questions that will occur. Then it'll be coming into the building. And depending on where the practice is, whether it be in a high rise or whether it be in a home office, will make a difference on how you enter the building and how you get to the office. A high rise, you'll have to enter the elevator, and there'll be social distancing in the elevator. In a private home office, you'll probably park in the parking lot and wait to be called to come into the office and go directly to the operatory. You'll be wearing a mask, and if you're not wearing a mask, you'll be given a mask. You'll probably be asked to sanitize your hands or wear a pair of gloves and then sanitize. And then when you get to the waiting room will look nothing like the waiting room in this picture. There'll be fewer chairs, or there'll be no chairs, and people won't wait in the waiting room, and they'll go directly to the treatment center. And of course, social distancing, there will be nothing in the waiting room. There'll be no books, there'll be no magazines, and that homey feeling will no longer be. And of course, the socially distance will continue to be happening. Personal protective equipment will change. There'll be more protective equipment. There'll be N95 masks, there'll be face shields, there'll be hair coverings. And those are the things to protect the dentist who's in the environment the entire day. There'll be less patients in the office at any one time. There'll be longer turnaround between patients. Patients may be socially distanced in different operatories, spread out. The disinfectant protocols will be enhanced. Instrument changes will be happening so that there'll be less use of a dental handpiece or an ultrasonic scaler. And management of the aerosols will take place using high-speed evacuation, four-handed dentistry, rubber dam placement, and pre-procedural rinses to try and minimize the aerosols that will occur. Ventilation, depending on the office and the building it's in, will take a new light, whether it be air changes, HEPA filters, and things like that. And lastly, the next appointment will probably be made virtually after the individual has left the office and taken care of over the phone. So we get to the end and we say, what about minimizing the risk and personalized care? So probably the greatest risk for any patient is getting to the dental office, especially if it's on mass transit. But even if one drives to the appointment, getting to the appointment is a significant risk, a greater risk than actually the risk within the dental office. And what about your personal risk? I think past dental history and previous risk assessment is important to determine the need to go to the dentist, let's say for your routine checkup. If you're an individual who gets cavities every time you go to the dentist, or you have significant gum disease, then you're a person who has high risk for developing issues and problems, and therefore preventive care on a regular basis is needed to minimize your risk. The older you are, obviously, the greater risk you pose of developing significant infection. And the medical history and comorbidities has been shown in the COVID pandemic to impact upon the outcomes of people who get infected with COVID. So taking all those things into consideration, one has to think about this. And you ask the question, can I go and see my dentist? Yes, it is safe to go. But always consider potential risks versus the benefit of the visit based on your personal history and your current needs. Thank you.
Good afternoon. My name is Bob Rubin. I'm president and CEO of the Loveless Biomedical Research Institute here in Albuquerque, New Mexico. Dr. Kadish asked me to give you a brief rundown on the current status of countermeasures to COVID-19 in the world, and I'll do so now. I'll start with vaccines. There are three categories of vaccines: mRNA vaccines, vector vaccines, and direct antigen vaccines. In the case of mRNA vaccines, a company called Moderna, working with a federal agency here in the U.S. called BARDA, is well along in the development of a messenger RNA vaccine. It's the kind of vaccine you inject a messenger RNA that's been engineered to enter cells and produce the antigens present on the surface of viruses, and that induces immunity. They hope to have a number of millions of doses by early 2021. Unfortunately, to immunize the entire country, we're most likely going to need 600 million doses. Most of these vaccines require you to get a booster, so you have to be vaccinated twice, and so they're a long ways away from 600 million doses. The second mRNA vaccine of note is produced by a company called Biotech in conjunction with Pfizer Corporation. They hope to have one of their vaccines approved by late 2021. They're studying 4 different mRNA vaccines. I'll point out that in 20 years of effort, not a single mRNA vaccine has ever been approved for human use. The second category is vector vaccines. These use another virus to transport the nucleic acids into the cells of the body and then produce the antigen. And the most noted effort in this regard is by Oxford University in conjunction with AstraZeneca. They hope to have 300 million doses by the first of the year. This is an amazing statement that they've made very recently, and I'm skeptical, but it would be a big deal. 300 million doses isn't enough, but it's a big start. The second effort that's well along is by J&J, Johnson & Johnson, in conjunction once again with BARDA. They're in phase 1 only. They are using a measles vector and a modified VSV vector. Merck Corporation has another phase 1 trial going on their adenovirus vectored vaccine, and they're in early stages. All of these large chemical companies need to be involved because they are the only ones that have the capability of producing the vaccine in scale. Now there are problems with vector vaccines in general, and that's because the vector itself produces immune response. A paper out of China recently indicated that about 50% of the perhaps world population has been exposed to adenovirus and is immune sensitive to the vector itself. So that could be a problem. The last category of vaccines are direct antigen vaccines. These vaccines use molecular biological tools to produce the antigen of the virus and inject that directly. Sanofi Glaxo have teamed up together to produce a direct antigen vaccine. This is very promising, not only because they're 2 big companies and probably could produce a large amount of them once they're approved, but Glaxo has a effective adjuvant that they're adding to the mix. Adjuvants increase the potency of the vaccine, so you don't need as much. They're in phase 2 trials now and hope to have something that could be used within the year. So what's holding up vaccine development? Number 1 is toxicity. All of these vaccines have proven non-toxic in animal models. That's good. Unfortunately, many vaccines produce toxicity when we go to people, and that really hasn't been tested yet. We haven't been through phase 1 testing in all cases with these vaccines. Some vaccines produce hyperimmunogenicity. That's a problem. If the vaccine induces the immune response to be too large, you get disease, and the vaccine cannot be used. Sometimes the vaccine will produce the wrong kind of immunity. It won't produce, say, neutralizing antibodies. It'll produce a different type of immune response. So you may get an immune response, you may have a vaccine, but people could still get infected. Next category of problem is that we may not have enough people who are being infected to undertake a successful phase 3 clinical trial. J&J estimates that they will need up to, in the worst case, 100,000 subjects in their phase 3 clinical trial to prove efficacy in their vaccine. I can tell you that a 100,000 subject clinical trial is a big deal and will not be done in a very short time. Lastly, we have the problem of herd immunity. For vaccine to protect the country, we're going to have to get enough people vaccinated to produce what's called herd immunity. Herd immunity means that once about 70% of the population has become immune, the virus naturally phases out, it can't be passed, and the pandemic is over. Unfortunately, poll after poll shows that up to 40% of the U.S. population is reluctant to be vaccinated, especially with a untried vaccine. So if you can have a good vaccine, but if you don't get herd immunity, we will still have a pandemic. It's estimated that between 1 and 10% at most of the U.S. population has caught this virus. So that means we have from 99 to 90% of the population yet to become immune competent. That's a long way to go. In terms of treatments, we have remdesivir, proven effective, and the trouble with remdesivir, produced by Gilead, is very expensive. 26-step synthesis, takes 6 months to make a batch, and you got to give it for a week. It's a big problem. My company's working to try to find ways to deliver it in different ways to reduce the dosage necessary. We also have antibodies, direct antibody treatments. A company called Regeneron is about 6 months away from approval, they believe, of a antibody therapy whereby they produce antibodies in vitro and apply these directly to sick people, thus neutralizing the virus in the blood directly. Again, this has not been proven and has not been approved. The bottom line is the virus is stable. That means once you become immune, you'll probably be immune for many years. And unfortunately, the virus is probably seasonal. 4 other coronaviruses have been studied. They're all seasonal. That means we'll have a spike in infections again this winter. And taking all of this together, my best guess is that we're going to be living with this pandemic for at least another 1 to 3 years. Thank you.
Hello again, everyone. Edward Halperin, your moderator, back again for a conversation with Drs. Renee Garrick and John Pellicone about what they learned running hospitals during the COVID-19 pandemic and how they might apply the lessons they learned to the potential of a second wave. Let's begin by not doing the New Yorker thing and assuming that everybody knows who we are and where we are in New York, since we have people throughout the United States joining us. So let's lay the groundwork. Dr. Pellicone, if we could start with you, please tell our audience where Metropolitan Hospital is, what it is, and at the height about how many COVID-19 patients you had in the hospital and in the ICU.
So we are located in what we affectionately call the upper East Side on 97th Street between 1st and 2nd Avenue in Manhattan. We're one of the 11 acute care hospitals that comprise the New York City Health and Hospitals system. And at the height of the pandemic, we had 53 COVID patients in our 4 ICUs.
Dr. Garrick, the same for you. Could you tell our audience what Westchester Medical Center is, where it is, and how many patients you had at the height?
Sure, thank you. So Westchester Medical Center is up in Westchester County, which is about 30 miles north of New York City proper. Westchester County was actually the 2nd largest epicenter in the country. And we had at our height about 225 COVID positive patients at once. And overall, we've treated about 1,300 COVID positive patients during the pandemic at this site. And we also have as our partner hospitals, 10 other hospitals in our network. And 3 of those hospitals are in on the other side of the river in Rockland County, which was actually the highest per capita epicenter of COVID in the country.
And when Dr. Garrick refers to the other side of the river, for the non-New Yorker, she's talking about the Hudson.
Right.
Dr. Pellicone looks out his window and sees the East River, where it meets the Harlem River on the east side of Manhattan. Dr. Pellicone, let's talk about what did you learn from dealing with the pandemic that you think would be an important lesson for colleagues around the United States listening, for how you organized the hospital and organized your response? And then we'll ask the same question of Dr. Garrick.
So one of the most important things we learned was to have the flexibility to expand our critical care and ICU services. We were able to do that by converting a PACU to a makeshift ICU. And we were also ready to change our on-call room floor to make them workable ICU rooms in a very short period of time. So the flexibility to actually convert the rooms and then fill them with the appropriate staff was one of the most important lessons learned.
Before we turn to Dr. Garrick, Dr. Pellicone, can you tell the audience a little more about the comment about the appropriate staff? We certainly read about people saying, well, we built infrastructure, we converted buildings to temporary hospitals, but then we couldn't staff them anyway. So what was the point of converting a convention center into a temporary hospital if there wasn't staff? Tell us about the staffing issue, please.
So since we had almost no regular patients with our ordinary diagnoses, and the clinics were closed, we had a staff of internists, internal medicine residents, surgeons, surgical residents, anesthesiologists, and their residents all at the ready and were prepared to work. And so they took up the bulk of the work in what were these expanded 4 intensive care units. In addition, New York City Health and Hospitals made available to us nursing staff, NPs, PAs, and attending physicians, all of whom were granted disaster privileges, and we were able to bring them on rapidly to be able to fill the needs in these expanded critical care areas.
Thank you. Dr. Garrick, what did you learn from the pandemic that you think is important that our colleagues elsewhere in the country ought to know?
So much like John, I think for us, the big 3 were planning, exquisitely careful communication, and the ability to be flexible and nimble. In February, we started thinking about what it might take to get through a COVID epidemic, and that was because of what was going on overseas. And we actually began in late February, early March, thinking about how we would reconfigure the hospital. And in early March, we had a town hall meeting. Little did we know at the time it'd be our last town hall meeting, that we would not be having such kind of gatherings. But at that meeting, we outlined for the entire staff, which was everyone obviously was invited, the plan for how we would deal with the COVID epidemic that we thought might be coming our way. And during that, we outlined how we would reconfigure the hospital and how we would use our ACP building, our ambulatory care pavilion, to basically think about creating 2 hospitals. And early on, we created a COVID area where we anticipated bringing COVID positive patients to basically be staged. Little did we know that we would overrun that in the first week. And then we had to start creating basically COVID positive floors. And we did that and learned a huge amount about the need to communicate very carefully with the nursing staff and the other staff so that they could follow the planning lead. Like John, in terms of staffing, we recommissioned the fellows as attending. So any fellow that met licensure requirements was able to work as an attending. And we restaffed the ICUs by taking the surgical staff, the anesthesia staff, and basically creating COVID teams, and restaffed essentially 2 hospitals, a COVID positive hospital, and then our ambulatory care pavilion, which became our COVID-free hospital. And very early on, we ramped up testing by partnering with outside companies so that we were able to get COVID testing, and we opened up the drive-through tent, which was extremely important because you can't treat what you can't test. So we tried to ramp up testing very early on.
Let's use a military metaphor, Dr. Pellicone. People will say the medals all get won by the infantry and the armored cavalry, but it's the quartermaster corps that makes sure that there's gasoline in the tanks and bullets in the rifles and the army gets fed. So let's talk about the supply chain to do this operation of caring for patients. What did you take away from getting the right equipment to do this? Masks, protective equipment, ventilators that you think people ought to know about?
So the PPE was certainly a point of controversy, beginning with the official recommendations about exactly which PPE should be worn in which situation. Fortunately, our hospital was able to keep up with the overall demand, although we did ask our staff to be prudent about the use of the supplies that were limited, such as the N95s. We made every effort to supply our staff, especially ones that had the direct patient contact, with the adequate protection. And I have to give kudos to our central supply staff who really worked day and night to keep the supplies coming from the vendors and from our central office up and to the folks who were actually taking care of our patients. And we fortunately never ran short of ventilators with our 53 ICU beds.
Dr. Garrick, I want to flip an earlier question that I asked. I asked you what you did well that you would recommend others. Let's talk about what didn't you do so well that you're not going to repeat. You and I, for example, before this webinar, have talked about what kind of clinical science might have been obtained from the pandemic that perhaps we didn't do so well at. So tell our audience, boy, I'm not going to do that again. What are you not going to repeat from the first episode?
So we created this kind of guidebook that we called the COVID manual, and we started collecting all kinds of things that were being done in many, many places for the treatment of patients with COVID. And I think looking back, we would have been wiser had we been more organized about how we treated every patient. We actually treated every patient differently from the standpoint of there was not harmony about that every ICU patient get hydroxychloroquine and remdesivir when it was available, and the IL-6 when we were in that trial. We were very good about making sure everybody got convalescent plasma, and we gave well over 250 units of convalescent plasma, and we ramped that up very quickly by partnering with the New York Blood Center and with our patient population. But in terms of good science, we did not harmonize our approach to therapy as robustly as I think we would now going forward. The only place I think we're exquisitely well harmonized was ventilatory management. We put together, like you were explaining, almost a military command system using our EICU. And that system drove a harmonized approach with an algorithmic care plan for the management of respiratory therapy and the management of the vents. That I think we did very well, and I would replicate that. In terms of how we treated patients with a variety of things that were available medically, we would look at that in a much more harmonious way and try to better organize how those patients were cared for. I would repeat what we did, though, from a ventilatory standpoint. I think the other thing that we would do differently is our communication cascade needed to be tighter. We were enormously well greased on the doctor side, but I think we were not as careful about how we communicated with all the rest of the thousands of employees. And I think we would find ways to do that more efficiently, especially for the night staff. I think we needed to learn better how to make sure that the folks who were here at night got all the same information as the folks who were here in the day, with the same kind of rapidity and clarity as the day shifts got that information.
Mm-hmm. Thank you. Well, our time's drawing to a close. I want to ask you if either of you want to comment on one final hot political topic. In the news yesterday here in North Carolina, where I'm sitting, the news reporters reported that a bill is now working its way through the North Carolina state legislature called the No Patient Left Alone bill, in which the state government will mandate that hospitals will be forbidden to deny families coming in and out of the hospital for COVID-19 patients, that every family will be able to identify one person who can visit them in the hospital, even if the hospital has policy saying for COVID-19 patients, we're trying to limit people coming and going. The local hospital association was very politically discreet about how they were going to comment about getting into this battle with the state legislature. But I bet if a bill's introduced here, it'll probably start showing up in other state legislatures. Would either of you be willing to comment on basic control of the infection by having the government tell you whether you can or can't have visitors coming and going with COVID-19 positive patients?
So I'll kick that off. I think that it's probably a little bit of a misguided legislation. I'm sure that their hearts are in the right place, but the concept that we could have managed open visitation for 700 people, if every patient was allowed to have a visitor during the COVID pandemic, would have enormously stressed the institution, and our frontline job is to take care of the patients. Because remember, every one of those visitors potentially had COVID. And every one of those visitors coming to patients who had COVID would have been potentially exposed, which would have been an astronomical increase in the amount in the community. And in addition, we would have needed to supply those patients with appropriate PPE. So we did have visitation. We had end-of-life visitation. We had in New York extenuating circumstances visitation. So we were never fully closed to visitors. We did have Zoom and Skype and iPads and other ability, but I think that it would be difficult for us to have had open visitation. I think we'd have spent a lot of time trying to control the visitors rather than taking care of patients.
Dr. Pellicone, we'll give you the last word.
So we certainly allowed the partners to visit for women in labor and for end-of-life situations that was permitted as well. We too used the iPads as the form of communication. I'd say that the problem here is what I would sum up as my greatest challenge, and that was managing a medical staff that struggled daily, differentiating scary versus dangerous, and there absolutely is a difference.
I want to thank Dr. Pellicone and Dr. Garrick for spending time with us today. They'll both be back with us later in the webinar for the question and answer period. And thanks to both of you for joining me in this conversation. Thank you. I hope you found the presentations interesting. This is Dr. Edward Halperin back again, your host for the program. It's time to turn our attention to the question and answer part of the program. But first, I've gotten a couple of questions on the question line. I know you showed me twice how to get CME credit, but I wasn't paying attention. Would you do it again? So get your pencils out. I'm going to do it one more time. You're going to send a text message to 828-295-1144, 828-295-1144, and in the text message, you're going to write 09, C as in cat, L as in Larry, O as in Oswald, and P as in Pepper, 09 clop. And if you send that text message, you'll get a response back giving you instructions as to how to get your CME credit, or you can go to the website www.eeds.com and do it that way. That's how you get your CME credit. I want to thank the people who have been making these webinars happen behind the scenes, who you will never see their faces. Amy Jacobs and Ashley McCarrick taking care of the organization of the webinar, and the wizards of IT, Michael Cotter, Frank Steen, James Coran, Juan Castro. Thank you for organizing the broadcast. Now, let's turn our attention to the questions. Many have come in on the question and answer line. Our first question is going to be for Dr. Robert Amler. Dr. Amler, thanks for all these erudite scientific presentations, but I have kids in the house for months and I'm at the end of my rope. Can I send my kids to summer camp?
Well, the answer is day camps, yes, and overnight camps, no. At least in New York and New Jersey, no overnight camps, sometimes called residential camps. Now, day camps, day camps can be open if they adhere to boatloads of requirements, all of them familiar. Campers stay outdoors in small family-like groups with social distancing, masks, frequent hand washing, and so forth. Daily monitoring for COVID symptoms, and swimming pools are okay, but they're at lower capacity with smaller numbers of campers in there at a time. Thanks for the question.
Thank you, Dr. Amler. Our next questions are going to go to Dr. Janet Piscatelli. We have two questions for you, Dr. Piscatelli. They're on the same theme. If you either did or did not have symptomatic COVID-19, and now you have a blood test showing you're positive for the antibodies, are you contagious? And the other question, which is in the same vein, is how effective or how protective are the presence of these antibodies?
Now, these are two really great questions. The first one is if you're still contagious, it depends, and studies are still ongoing. People can have a positive PCR test, which we're not sure whether it's active virus or non-viral particles for quite some time. It's been seen up to 4 weeks in the respiratory tract and quite longer in the stool. So people can still be shedding virus while they have antibodies. So we're not clear yet on whether that you're still contagious or not once you have antibodies. It seems for a short period of time you are contagious. The second question is whether it's protective, and you have to remember that most of these antibody tests are qualitative, so we don't know at what level of antibody confers protection. And also we don't know if these antibodies will abate, and so having antibodies does not necessarily mean that you are protected from getting a reinfection, although it's unlikely. Thank you.
Thank you, Dr. Piscatelli. The next question that's come in from one of our listeners is for Dr. Jerry Nadler. The listener wants to know, Dr. Nadler, would you comment on whether there's a difference between type 1 versus type 2 diabetics when it comes to an increased risk to the patient with COVID-19?
Thank you for the question. Really, intuitively, there's really no reason to think there's a difference between the risks to a patient with type 1 versus type 2 diabetes that gets infected with COVID-19. Part of the excess risks deal with the underlying complications that the patient may have, such as cardiovascular disease, renal disease, but in particular the patient with type 1 diabetes, you have particularly be concerned with diabetic ketoacidosis, which could be a risk of a viral infection. So really both patients have risks, and the best way to avoid these is to prevent the patient from getting the disease. Thank you for the question.
Thank you, Dr. Nadler. We have a question for Dr. Pellicone at Metropolitan Hospital Medical Center in Manhattan. Dr. Pellicone, the questioner writes, I'm interested in the problem of muscle breakdown and muscle atrophy in patients afflicted with COVID-19. And I'd be interested in your thoughts about how you'll be managing the physical rehabilitation of these patients.
Thank you. An excellent question, because certainly there is a difference between surviving the illness and thriving. And that's what rehabilitation medicine is all about. Certainly we know that putting the patient to bed, especially in the ICU, leads rapidly to muscle weakness and overall deconditioning. Here at Metropolitan Hospital, we're fortunate to have an inpatient rehabilitation unit, and we made a decision very promptly that we would accept deconditioning following COVID ventilatory failure as an indication to come to our inpatient unit, including those patients who continue to have tracheostomies and are weaning from the remnants of their ventilatory failure. We also expect to see these patients in our outpatient department in both physical and occupational therapy.
Thank you, Dr. Pellicone. We've had a question come in for Dr. Renee Garrick. The question for Dr. Garrick is, I've read about some research papers suggesting that patients with type A blood may be more susceptible to COVID-19 infection. Do you think that's true? And if so, is there anything clinically to be done with the information? Obviously, the patient can't decide to change their blood type. So is there anything you're going to do about information of alleged differential sensitivity as a function of blood type?
Thanks very much for the question. So there was some early reports that type A blood was a risk factor and the type O blood may be protective. Whether that will hold up as we find out more worldwide about COVID remains to be seen. I think what people are thinking about in terms of how we might use those early data to protect patients would be the ability to test blood type and then think about that population as one that might get remdesivir or other protective drugs early on during the treatment. I think we saw this week that there were new trials about dexamethasone being able to be used in much smaller doses than one might have considered as also being helpful in the cytokine flare So if we knew that patients with type A blood were particularly susceptible, that would be a population we would go after quickly. Same would be true of preferential use of convalescent plasma. So if it turns out that blood types indeed are linked to increased risk, we would certainly try to use that clinically to engage in more rapid care of those patients and prioritize their care. There's also early data about HLA typing that might turn out to be useful as well regarding the risk factors with HLA 46 potentially having an increased risk. So lots more to come, but we're going to try to apply those clinically as we can.
Thank you, Dr. Garrick. Dr. Garrick, can you stay on, please? And if Dr. Jerry Nadler could also come on. A question has just come in that I'd like to pose to both of you, and that is, people have talked about hypertension as a risk factor for COVID-19 affected patients, but the questioner wants to know what happens if you're taking your blood pressure medicine and your hypertension is well controlled. Should you still be considered at higher risk than the average person?
So I could comment first. We looked at our comorbidities and actually discovered that the comorbidity profile of our patients was vascular disease much greater than respiratory disease. So hypertension, hyperlipidemia, and vascular disease were very common comorbidities. So in our hands, we tried to look quickly at the literature about antihypertensive meds, and I think many people saw that early on people were suggesting that individuals stop their ACE inhibitors, and then there were studies that came out in the New England Journal suggesting that that should not be done. So we certainly tried to control patients' blood pressures. We did not recommend that patients at home stop their meds. I'll yield to Jerry to see what he thinks about it, but we certainly tried to continue to control blood pressure, especially in view of what seems to be a very high vascular risk of this, COVID.
So it's a good question. I think the question about antihypertensive medication, particularly medications of the renin-angiotensin system, which are commonly used, there's clearer data. There's now 3 or 4 studies that show that the risks of staying on those medications does not pose a greater risk of disease. And there's a recommendation, as Dr. Garrick said, to patients staying on those medications. And the comorbidity related to hypertension is related to the risk of cardiovascular disease and other comorbidities that go along with it, including obesity and diabetes. So it's hard to say that hypertension alone is a risk factor. And if it's well controlled with the appropriate medications, the risks would be less, most likely. However, patients that have hypertension often have other comorbidities such as cardiovascular disease, obesity, and diabetes, and all of those in concert lead to higher risks. So that's where the take-home point is well controlled patients on hypertensive medications. That's the best idea in prevention of disease.
Thank you, Dr. Garrick, and thank you, Dr. Nadler. We've had a couple of questions that have come in for Dr. Rubin in New Mexico. Dr. Rubin, it looks like we've got 2 questions for you. First, the questioner wants to know what the role is of testing the potential vaccines in non-human primates. And second, he didn't cite any research being done by the Military Medical Research Program in the US. Is there anything you can tell us about the role of military medical research in responding to the pandemic?
It's a good question. Thank you. And first, in regards to non-human primates, they're absolutely essential to prove safety and efficacy in all vaccine trials and in treatment trials as well. The FDA requires that you prove safety and efficacy in 2 species of animal model, usually a rodent and a species of non-human primate. That's no different from what's going on right now. The FDA is allowing, however, in the current pandemic, proof of safety in rodents and non-human primates to be sufficient to enter into phase 1 clinical trial of safety in people, whilst the vaccine or the treatment is being studied for efficacy in non-human primates. If it passes that test, and it passes the phase 1 trial, then the FDA is allowing protocols in phase 2 and phase 3 for efficacy to proceed. So they've sped up the process quite a bit. We find right today that as numerous vaccines advance, and there are over 100 of these in the world now that are moving along, we have a paucity of non-human primates for this research. In fact, it's now becoming rate limited. We're finding that a number of treatment and vaccine programs are being delayed because we can't get access to non-human primates in sufficient type or volume to do the preclinical testing. On the second question, we learned after the anthrax attacks that the Department of Defense was very concerned, very active, but very slow in the development of vaccines and countermeasures to threats of that sort. And that's proving to be the case here. They're not really set up to rapidly develop new therapies. They're going to be piggybacking on the type of studies that I talked about earlier, where the pharmaceutical company is taking the lead. And I think the Department of Defense is going to have particular needs related to their patient population, and they're going to be picking and choosing from commercially successful efforts in the future. But right now, from what I can see, is they're not playing a very big role in rushing a vaccine or a therapy out to the public.
Very good. Thank you, Dr. Rubin. Well, we've got a bunch of questions which have come in because I guess our audience is not done with Dr. Robert Amler. The first here is, Dr. Amler, people seem to be getting lax with their social distancing in New York City, yet the number of cases is said to be falling. Would this indicate to you that we're seeing some evidence of herd immunity?
You know, it's not clear when we'll get herd immunity. Dr. Rubin mentioned it earlier. It's going to be some time before we can factor that in as a practical matter. The lax behavior is not something we like to see. The decline in cases is something we love to see. And we're seeing this not just in New York City, but around the counties. And we know this in particular because at New York Medical College and our Center for Disaster Medicine, we're in very close contact with the health commissioners of all the county health departments. In fact, they're all members of our faculty. So we get regular reports of what's going on. The number of cases, the number of hospitalizations, the number of deaths are all declining. But let's be logical. Without vaccines yet, without readily available meds, all we really have going for us is the same imperfect but solid defense that works and has worked literally for hundreds of years without medicines or vaccines. And that is very simply, we've got to keep blocking the exposure, stay away from people who might be infected with social distancing, masks, regular hand sanitizing, washing, and so forth. And let's all do the best we can to block that exposure. And thank you for the question.
It looks like our audience is still not done with you, Dr. Amler. Another one came in, and this one is, thanks for the information about the summer camps, but when can I go see my grandchildren?
And that is a question that's really on everyone's mind, not just parents of school-age children, but all of us who have older relatives. Well, as we just discussed in the previous go-around, what are you going to do to block exposure to your family, friends, and loved ones? You want to see the grandparents. You want to see your aunts and uncles who are older. If you do go see them, what are you going to do to block exposure? Can you see them outdoors, outside the house or in a park at a safe distance? Will you mask up? Will you avoid contact with surfaces in their homes or keep them safe from contact with you? If you can see them socially without getting them exposed, then you're probably going to be okay. But remember, the word is probably, because you do everything you can to block exposure, but you can never be 100% perfect. So do what you can. Don't beat yourself up about it, but do try to, once again, block that exposure. Thank you for the question.
Thank you, Dr. Amler. We're going to turn the program now over to Dr. Alan Kadish, the president of the Touro College and University System, who welcomed you at the start of the program. Dr. Kadish will offer us some concluding remarks and may want to have a further dialogue with our panelists. And one last time, for those of you who keep asking me about the CME, send the message 09CLOP, 09CLOP, text it to 828-295-1144. Dr. Kadish, the floor is yours.
Thank you very much, Dr. Halperin. I'd like to first thank all the panelists for great presentations and telling us what we've learned about the COVID-19 pandemic and what more we have to learn. I think we can be heartened by what our hospitals have learned about how to better take care of patients with COVID-19. We can be thankful that there are a couple of drugs, remdesivir and dexamethasone, that have shown some efficacy in helping the sickest patients. We can be thankful we've learned more about risk factors. What we've seen is that we still have a good deal to learn about how to use and best implement testing, how we prevent the disease with drugs early on. But we do, as Dr. Amler said, have social distancing and maneuvers such as that that have proven effective at preventing the spread of COVID-19. I want to close by asking the question really that everyone wants to have an answer to, and no one has a definitive answer to, is what can we expect over the next months and years? So Dr. Rubin has to some extent already answered the question by telling us that he believes it's going to be 1 to 3 years of the pandemic. And so I want to start with Dr. Rubin by asking him, is that because you don't see any way to really get rid of the pandemic short of a vaccine, and that's how long you think it will take to develop an effective vaccine?
That's exactly correct. There are so many stumbling blocks in the way of getting an actual vaccine to your physician that I can't imagine that will be available in under a year. And that's if the vaccines, one or more of them that are being rushed to completion, are effective. I might point out that many vaccines have proven to be effective in young people, and they just don't work in older people. And so you might get a vaccine that is useful in one part of the population, but just doesn't work for the people who are at greatest risk. So I'm very cautious about expecting this pandemic to be over right away. I'm much more optimistic about us developing effective treatments that slow the mortality. And as I said, I'm sticking by my 1 to 3 year prediction before we will have massive doses of vaccines in the United States.
So Dr. Garrick and Dr. Pellicone, you're most on the front lines in dealing with COVID-19, and you've seen how patients respond. We've talked about treatments that Dr. Rubin just referred to that can help people who are quite ill with COVID-19. Is your sense that we're any closer to finding treatments that will stop the spread of the disease early on? So Dr. Garrick, do you think that can make a difference in tackling the pandemic?
I don't think we have anything yet prophylactically that we would be able to give to patients to all of us to be able to protect us from spreading to others. That's why I think that Dr. Amler's point about social distancing and viewing masks as a medical device at the moment is critical. In our hands, this disease really looks like it has 2 phases. The first is the viral phase, and the second was the cytokine storm. People who made it through the early viral phase, especially younger people, seemed to do quite well, and they went home quickly. And then the cytokine storm group was a different population, and drugs like remdesivir and dexamethasone and steroids might be more efficacious. But I don't think yet we have a way of protecting each other than distancing and masking. I don't think we have anything on the horizon yet to do that.
There was a question about college dorms. And so I'll spend the last couple of minutes talking to you about the challenges of education in the age of COVID. Touro and New York Medical College, as well as every other college and university in the United States, are struggling with what to do in the fall. And I would say the same thing about K through 12 education. The governor of New York State today announced that he has no idea yet if the schools will be open in the fall. Some colleges and universities have said they'll be open. Some have said they'll be online only, except for extraordinary education. And some have said, we're going to do something in the middle, but we don't know what that is yet. And some have taken an unusual approach, like Harvard, who will have their undergraduates on campus, but will have their classes done remotely. The bottom line is, regarding how to handle the risks of bringing students onto a campus, whether it be a commuter campus or a residential campus, there's really no consensus, because a lot of the unknowns that you've heard about today apply to college campuses. Will testing help? Does it make sense to test everybody? Is that going to really be effective at preventing the extent of disease? Will college students abide by social distancing or not? What do we do about faculty, particularly older faculty who are at higher risk, or faculty who say, I don't want to be exposed to the risk of being on campus, even if my students do? None of those questions has clear answers. And of course, the dormitory question, which came from the audience, is one of the most complicated of those. What many schools are doing, of course, is going online only, and therefore dormitories are not a problem. The schools that have dormitories, and this is consistent with what some of the state universities in New York have announced, is limiting situations to 2 students in a room and a small number of students per bathroom, and creating, quote, family units of students to isolate them together the same way we would quarantine a family together. And of course, having quarantine abilities if students do end up developing symptoms. The bottom line is, what we really need to know to decide what's safe for a college campus come the fall is, what will the incidence of infection be come the fall? We know that, as has been mentioned, New York State has made great progress despite the concern about backsliding because of less effectiveness of social distancing. But we know that as of yesterday in Westchester, the incidence of positive infections of those people who was tested were under 1%. Well, if the incidence stays that low, I think we'll be okay. But we do know that super spreader events, where one student or one faculty or staff member can infect many people if we're not careful, will still be present. The bottom line is, I think every college and university, including ours, wants to be open in the fall. Exactly how open we can be and still keep our students and staff and faculty safe, which is of course our primary concern, still remains to be determined. New York Medical College is going to have some laboratories and experiences that are hard to recreate virtually open, but do much of his education virtually, except of course the clinical education, where as much as is possible, we'll have students back on clinical rotations. At Touro, where we have an undergraduate school, we'll have some combination of in-person and distance education. We'll have some students back in the dormitory, but certainly not the full complement and density. And if anyone here has a clear answer to what we should do, just as with many of the questions we've asked today, please send me an email and let me know. The bottom line is, I'm very concerned about what's going to happen over the next 12 to 18 months, but I'm optimistic that we've learned a tremendous amount since January 29th, when New York Medical College Center for Disaster Medicine did its first COVID seminar. And I'm hopeful that as time goes forward, the knowledge that we've gained from basic science, epidemiologic, and clinical work moves forward in getting us closer to a solution to this pandemic and getting life as close back to normal as we can. In the meantime, stay healthy. We'll be back with you in about a month and let you know where things stand and how we're moving forward. And good luck to everyone on the conference. Have a good day.